name's Nicole Green. I'm the Acute Oncology and Cancer of Unknown Primary CNS here in the L&D. So neutropenic sepsis is when patients on chemotherapy, when the chemotherapy affects their immune system, and it can drop their neutrophils at any point during their chemotherapy treatments. Normally 7 to 10 days after chemotherapy, but can be any time between their treatments. Patients won't know in themselves when their neutrophils are low, unlike if you're anemic or anything like that. So we have to tell our patients to be cautious of neutropenic sepsis and the risk of infections throughout their chemotherapy. So it would be a patient who is pyrexic at over 38 degrees, although the pyrexia may not be present. They are tachycardic, they are hypotensive, they may be shivering, shaking, rigoring, they may have oral mucositis, they may have diarrhea, they may have altered mental state or feeling confused and agitated. Okay, so patients can feel generally unwell with their chemotherapies. A lot of the toxicities can cause non-specific feelings of just not being right, but that could be a precursor for the patient having neutropenic sepsis. So we absolutely would consider that a trigger to consider neutropenic sepsis in a patient. If you know that they've had chemotherapy within 6 weeks, and these patients will present with an alert card and they will say, I'm on chemotherapy, we need them triaging speedily, highlighting that they may be neutropenic, and we have an active cancer sepsis sticker which helps the triage nurses to clarify whether a patient is at risk of neutropenic sepsis. That patient would need to have their bloods taken, but we do not wait for their blood results. We give them IV antibiotics as quickly as we possibly can, and then we diagnose them if they're neutropenic once we get their blood results back, but they've already had that first dose of antibiotics. So we would advise that that patient is reverse barrier nurse for the patient's own protection. So that would include us using gloves, aprons and masks if appropriate to look after the patient while we are suspecting neutropenic sepsis for them. We need to consider neutropenia in every sick patient who has had chemotherapy within the past 6 weeks. With immunotherapies, rather than patients being at risk of a neutropenic sepsis episode and acute infections, it is more the immune response related side effects that these patients are at risk of. Okay, so with immunotherapy complications, where it's immune modulated responses that these patients are having, it is a lot of your itises that they will be suffering from. So it'll be patient with colitis symptoms, with pneumonitis symptoms, with hepatitis, nephritis, with thyroid dysfunction, rashes, uveitis of the eyes. It's a lot of these immune response symptoms they're having. Patients will have an immunotherapy alert card. So similar to the chemotherapy alert card, it will kind of give you a snapshot of the things that you need to be aware of. And if patients have any signs of those symptoms, we do have more in-depth immunotherapy guidelines on the intranet that you can access from the A&E department and use to base your assessment on. So metastatic cord compression is when a patient with metastatic cancer has a cancer within or external to their spinal cord that is compressing upon their spinal cord. Please be mindful that 23% of patients with metastatic spinal cord compression do not have a cancer diagnosis, and this is their first presentation with diagnosis of their cancer. So the red flags for metastatic spinal cord compression include back pain or band-like radiating pain, limb weakness, difficulty in walking or falls, neurological weakness in their legs, sensory loss, bladder or bowel dysfunction, including loss of anal tone, and if they've got known bone metastases. So we treat from suspicion of metastatic spinal cord compression. First line treatment is high dose steroids, so 16 milligrams of dexamethasone with a PPI cover, making sure the patient has adequate analgesia and that they have an urgent whole spine MRI requested that should happen within 24 hours. To find our acute oncology pathways, we go to departments and wards, through to cancer and palliative care, and down to acute oncology pathways. And within here you have all of our pathways available for you, including the spinal cord compression, neutropenic sepsis management, and management of immunotherapy related adverse events. There are lots of other acute oncology presentations that someone may come in with. We are more than happy to help with any of these patients. Just please call us and we will come and assist you. My name is Nicole Green and I am Bleep 011.